Good morning, everyone. We'll give a couple minutes to let everybody get on. Okay, good morning. My name is John Strauss. I'm the founding director of MCPAP, and I'm not usually the one introducing these talks, but our MCPAP for Moms medical director, Aruj Haider, is actually returning from maternity leave next week. So she'll be back doing these next time. But I'd like to welcome you all to the MCPAP for Moms webinar series that we try and do quarterly. And the topic today is the interplay of trauma and substance use disorder in perinatal patients. A few housekeeping issues. We are recording the session and it will be available on the MCPAP for Moms website, www.mcpapformoms.org. Also, there will be a copy of the slides and from the PowerPoint presentation. Our presenter will stop for questions if they're appropriate, but in general, try and save them for the end. And if you have a question or a comment, you can type it into the chat box, or you can raise your hand and and you can then unmute and ask your question. You will receive a brief survey following the presentation, and we really appreciate your feedback as this helps improve future presentations. So today we're very happy to have a distinguished presenter, Dr. Polina Teslar. Dr. Teslar has completed her medical school work at Tufts and a psychiatry residency at the University of Maryland, Sheppard Pratt Psychiatric Residency Program. She came to Boston Women's Hospital as a Brigham Women's Hospital, sorry, as a consult liaison psychiatry fellow in 2013. She joined BWH psychiatry faculty in 2019 when she returned the hospital to work in CL psychiatry and women's mental health. She is also the interim director of the Division of Women's Mental Health and Reproductive Psychiatry, as well as director of the Women's Mental Health and Reproductive Psychiatry Fellowship, and director of the Women's Mental Health Training for Psychiatry Residents. In addition to being a psychiatric consult for MCPAP for Moms, she is the Associate Director of Substance Use Disorder Program for MCPAP for Moms. Her focus has been on collaborative care across OBGYN, NICU, and psychiatry. So again, a reminder that you can type a question into the chat or raise your hand. And with that, Polina, floor is yours.
Thank you so much, John. And thank you everyone for logging in. I really appreciate you giving your time for this. So I'll be talking about promoting maternal mental health during and after pregnancy in women with substance use disorders. In terms of disclosures, I don't have any financial disclosures, but it is important to note that all medication use in pregnancy is off-label, and including any medication use that I will be describing in my talk or discussing with you today is off-label prescribing. What we will be focused on today is substance use disorders in pregnancy, mental health in general in pregnancy, the postpartum and breastfeeding period, as well as how MCPAP for Moms can help you. So I think it's very important to start with the obvious, and that is that women with substance use disorders can present at any point in their pregnancy and postpartum period to care. And so we need to be prepared to meet them wherever and whenever they show up in our offices. It is also true that in the United States, nearly half of all pregnancies are unplanned, and thus women with any kind of health complication, including substance use disorders, may find themselves pregnant at a time that they did not expect or plan for. When you factor in other issues that go along with substance use disorders, like more likely to have irregular menses, it is even more common for women with substance use disorders to have unplanned pregnancies, and it is very common for them to actually present to prenatal care later than typical, or to not know that they are pregnant for a longer period of time. The biggest reason why we're all taking time to talk about this is this very frightening statistic. The latest data from the Maternal Mortality Review Committee is that mental health conditions, and by mental health conditions, they do include things like suicide, substance use disorder, and overdoses, but mental health conditions are now the leading cause of death in perinatal women. So I think it's very important to really acknowledge that. The pregnancy is a high-risk time for a lot of things, but the number one cause for mortality in our country is mental health and substance use disorders in this population. As you can see, unfortunately, this trend has been very progressively climbing. This data point is only till 2014, but the curve, I think, becomes even steeper in the COVID era. Another similar view of the data, this one going to 2021. The overdose deaths are actually it may be hard to see with the small graph, but the bottom of that graph, those are the lines that are logging overdose deaths in pregnancy postpartum, with the late postpartum period being the highest risk time. That's that dark orange line. We also know that while opioid use disorders are a leading cause of mortality for maternity patients, treatment with medication saves lives, and it saves lives in a very significant and big way. Couple of key points from this chart. If you look, this chart goes from sort of like the overall rate to pregnancy and then the postpartum period going about a year out. If you look at the blue graph on the top, the thing I want you to take away from that is that overdose deaths decrease in pregnancy, which I think we intuitively would sort of expect that to happen because pregnancy is a highly motivated time. There are more resources available. Many patients are able to abstain during pregnancy. But then if we look at that postpartum period, especially 7 to 9 and then 10 to 12 months, those overdose deaths skyrocket again. And there are a lot of reasons for that. And one of them may be that that's actually where a lot of the resources and supports start to be peeled back and pulled away. So it's a very high risk time for relapse and overdose death. The chart on the bottom is comparing patients who are receiving medical management of their opioid use disorder versus not. So the orange lines are patients who are being treated with things like buprenorphine or methadone. And the gray bars are patients who are not being treated with medication. And as you can see, there's also a very stark difference there in overdoses. This graph looks at the racial disparities that exist in this space. A lot of media coverage has been focusing on the increased fentanyl deaths. Fentanyl really is making it much harder to treat this patient population. And I'll talk about that a little bit as we talk more about specifics of treatment. But it's also important to notice the vast differences by race and ethnicity. And for those of you who can't read it because it's so small, but those very, very high bars on the right of the screen are actually American Indians. And then the top chart is looking at men and the bottom chart is looking at women. So this is not necessarily perinatally related, but just differences by gender. So, substance use in pregnancy is obviously not something we advise. And I think we all recognize that it's detrimental to the health of the patient and her fetus. But it is also really important to understand that, again, that, most people are trying to do their best, especially when they're pregnant. They really do want to do what's best for themselves and their fetus and their future baby. And so we need to think about if there is substance use going on, why is that happening? There's a very strong correlation between substance use disorders and trauma disorders, other, significant mental health conditions. And we also do know that, again, because pregnancy is a highly motivated state, for patients who are not able to abstain during their pregnancy, we do think that there may be a higher level of illness, and a more severe dependence that they're not able to completely abstain. So coming to it from a perspective of sort of curiosity and understanding rather than judgment is really important, because many of these patients are very scared to present to care. They're worried about being judged. They're also worried about what the consequences might be if they are seeking treatment. But we do think about, what are the risks? So early on in pregnancy, certain substances may be teratogenic, and we worry about that. We also know that patients who use substances are less likely to engage in prenatal care. They have perhaps less access to prenatal care. One of the things we've been trying to work with our substance use provider colleagues is when they are treating patients who are pregnant, not to take for granted that they're also seeing an obstetrician and actually directly ask them that and help them connect. We also know that patients with substance use disorders are more likely to have poor nutrition, and that can lead to problems like placental insufficiency, growth restriction, things like that. Their labors can also be much harder to manage, and that can be for a variety of reasons, including active withdrawal or maybe pain control. Both they themselves and the newborn can suffer from withdrawal at delivery. And then, of course, we always worry about overdoses and the possibility of death and infectious diseases. If patients are using substances that require, injection, they're at risk of HIV and Hep C. Sometimes patients who are using substances also may be engaged in unsafe sex practices that can also leave them at risk for infection. So these are all things we would want to counsel the patients about. Kind of discussing again more what I was saying before, it is an opportunity for change. It's really important to engage with the patient and help them understand that you're a safe person to discuss this with and talk about how to get well. We need to be able to, think about our own reactions, our own feelings. Often there's very strong emotions when working with a patient like this, and sometimes that comes through and patients can feel it as well. They also can have legal issues that are complicating the situation. They may have questions about DCF. There may be facing criminal charges already and thinking about what kind of impact that will have on their delivery and what will happen to the child afterwards. We really want to make sure everybody's being screened for substance use disorders in pregnancy. And I want to make a point here that when I say screen, I don't mean toxicology necessarily. When I'm talking about screening, I'm talking about more like screening as in a conversation, a diagnostic evaluation, asking a patient about whether or not they're using substances, whether they've ever had a substance use disorder in the past. Toxicology may have a place in this as well, but one of the things that there's a lot of recognition now is that toxicology practices that have been in place for a very long time were fraught with a lot of disparity and bias, and would sometimes lead to unintentional consequences. So, when I was training, it was pretty common that a patient who came in for labor and delivery had a urine toxicology screen. There was no conversation about it. All the labs were just drawn. Urine sample was taken. And then all of a sudden there was something, a test result that was unexpected. And then everybody's sort of like, what are we supposed to do with that? And there wasn't really informed consent with the process. Many hospital systems are now moving away from that and have policies in place that any sort of toxicology screening needs to be done with informed consent and for clinically relevant reasons rather than just like sort of universal or ad hoc screening. One of the things that we at MCPAP for Moms can be very helpful with is on our website, we have a lot of toolkits for various clinicians, and including toolkits on how to do the screening and have this conversation with the patient. So this is just an example of one of the algorithms that we have that are totally free on the website of how to think through whether the patient needs screening or not, how to talk about it with the patient. And as I was saying before, the actual lab tests are really only just a piece of this and shouldn't be the default way to screen for this. Certainly, you shouldn't be getting toxicology screens on a patient without having a conversation first and discussing like what the patient thinks may or may not be found on the test. It's also important to know what kind of testing your system has. Some are screens, some are like more elaborate testing that are more confirmatory. So there are possibilities of false positives, and you need to be prepared to know how to react to that and what to do with that information. The other thing to think about is there's the screening on the obstetric side of the actual pregnant patient. But there may also be screening that happens on the pediatric side with the neonate. So sometimes if there are reasons to do this, maybe that the neonate is lethargic or having maybe like respiratory issues, or there's something going on that the pediatricians are concerned about, that they're not sure what's going on with the newborn, they may decide to test the meconium or the cord blood for substances as well. It's important to understand that like a urine or a blood test for toxicology is only going to tell you about use in the last couple of days, maybe a week for most substances. Meconium will actually test for anything that was ingested in the second trimester or beyond. So also important to understand what you're actually testing for. ACOG, CDC, AMA, American Academy of Pediatrics all recommend universal screening for substance use disorder in pregnancy. Again, not the toxicology screen, but the actual like diagnostic screen. They also recommend universal screening for perinatal depression and other mental health conditions. This is one of the screeners that we recommend using at MCPAP for Moms. It's a modified NIDA quick screen. So it's, as you can see, very quick, very short, only 4 questions. The expanded. And then another very popular tool is the tobacco, alcohol, prescription medication, other substance tool, which can help you risk stratify the patient in terms of their risk of substance use. So screening is important. Screening is one piece of the puzzle. What happens after you've done the screening and you discover that the patient does have an illness and needs to be treated? So it's very important to be prepared to intervene at that point. And whether that's something that you're going to do directly and you're going to provide the treatment, or you're going to refer out, either one is fine, but just screening is not enough. Screening is not the end. When we talk about treatment with patients, one thing that is very, very important, both for us to understand and to make sure the patient understands, that when we're talking about treatment, we're not talking about the risk of treatment versus nothing. Everything carries its own risk. What we're weighing is the risk of treatment versus the risk of lack of treatment. So another way to say it is the risk of treatment versus the risk of the illness. Oftentimes, patients are very hesitant to take medication or engage in treatment because they're worried that they're going to somehow harm their fetus. And what we want them to understand is doing nothing does not mean that they're not taking on a risk. If anything, there may be higher risks. Another thing to think about with patients with substance use disorders is to anticipate what might happen at the delivery time. So as many of you know, in Massachusetts, there's no DCF filing when a patient is still pregnant, but we may have situations where we're anticipating that there will be a filing after the newborn arrives. And I think in those situations, if we think there's going to be a filing, it's really important to start working with the patient very early on to prepare them for that. The state is currently developing a new family care plan, used to be called the Plan of Safe Care, to help guide clinicians and their patients on how to do this. But what you don't want it to be is a surprise. and for the patient to feel blindsided or unprepared. Want to make sure their whole team is there to support them through the process. It used to be, at least in my hospital system, that any opiate use, whether it was prescribed, appropriate, under physician supervision, was automatically reported to DCF. We've moved away from that. We now only file if we think that there's actual risk. But patients who are engaged in active collaborative care, that is not an automatic filing. This is new enough that patients may not know that yet. And so I think it is also worth discussing with patients, because I've definitely had patients who have had substance use disorders and they come in and they want to get in treatment, but they say, I can't be on buprenorphine. I don't want you guys to file with DCF. So we have to have this conversation that this has evolved and is a much more collaborative and I think better approach. But not everybody knows that yet. And it's also important to think about your own institutional policies and whether they make sense or not as well. Okay, so let's talk about the different substances. I will start with cannabis. So cannabis is a really hard one for us. At least I find clinically that patients are more and more likely to be using cannabis in pregnancy than they had historically been. I think one of the reasons for that is that it's now recreationally legal in Massachusetts. And so patients have this thought of like, well, if it's legal, it can't be so bad. I also hear a lot of like, well, it's natural. I hear a lot of patients talking to me about, well, it's the only way I can eat. My hyperemesis is so bad if I don't smoke cannabis, I absolutely will not eat. So we have to sort of talk to them about what is it doing for you? What are we worried about and what alternatives are there? And then, if all else fails from a harm reduction perspective, I'll also talk about sort of street supply versus dispensaries. So what the data tells us is that about 48 to 60% of patients who smoke cannabis do continue in pregnancy. The concentration of THC in the product today is significantly higher, like many log folds higher than it was in the 1970s. And that can have significant consequences. There's very, very limited human data on cannabinoids and cannabis in pregnancy, but we do have some. We do know that patients with lower socioeconomic status are more likely to be using cannabis in pregnancy. There isn't really enough data to suggest that there's a teratogen effect, but we do know that there are developmental effects. There does seem to be a growth restriction with cannabis use in pregnancy. It does seem to cause blood flow problems to the placenta. Fetuses do have endocannabinoid receptors, so they are getting the effects of the cannabis presumably as well. There are some studies to show that there is a difference in like gray-white matter differentiation in the brain and some behavioral studies looking at offspring. Limited data, but there are some concerns. There's concerns about visual processing development, attentional problems, behavioral problems in school. We also know that because cannabis and THC is so lipophilic, meaning it likes fat cells, it tends to concentrate very, very heavily in breast milk. And so I actually will talk to my patients about, even if they're smoking cannabis in pregnancy, even more strongly feeling that they shouldn't be if they're going to be breastfeeding, because then the amount of passage in the milk is that the newborn will get 8 times higher concentration than the adult is ingesting. We also now have data to suggest that actually paternal cannabis use can affect the sort of like the epigenetic changes to the sperm and can affect on the offspring as well. So that's new data coming out. That's very interesting, that it's not just maternal use, but paternal use plays a role here as well. And the other thing that I talk to patients about is if they're going to absolutely use cannabis, to think about where it's coming from. The reason for that is that in Massachusetts, the dispensaries are required by law to ensure that there are no pesticides in their product. Whereas things that are coming sort of like from the street don't have that oversight or regulation. We know that the pesticides themselves can be teratogenic. Excuse me. So if a patient is going to be using cannabis, that I would talk to them to at least make sure it's coming from a dispensary. Okay, alcohol. So I do have a slide here with a picture of the sort of stereotypical phenotype of somebody with fetal alcohol syndrome. But I will point out that a person does not have to look like this to have fetal alcohol syndrome. So while this is kind of the stereotypical common representation, we should be careful that sometimes patients or children or adults who have fetal alcohol syndrome don't have a typical physical features of it, so it can be missed. We do know that alcohol is a teratogen and can cause fetal alcohol syndrome. What we don't know is how much. So one of the challenges with recommendations around alcohol use in pregnancy is nobody really knows where the line is between it's okay and too much. The guidelines are different in the US versus Europe, which sometimes can cause confusion for patients. It does appear that a binge drinking pattern is much more worrisome than somebody who has a single drink here and there. About 12% of pregnant patients do report that they continue to use alcohol in the prior month to their visit. Another thing that can often happen is sometimes patients are not aware that they're pregnant when they've been drinking. So sometimes patients can come in worried about, I was at a wedding, I had all these drinks, I didn't realize I was already pregnant. And so sometimes they're looking for reassurance around that. In terms of fetal alcohol syndrome risk, it does seem the first trimester use is the time that is the most concerning. And that's when it should be limited the most. There's also some data to suggest that with alcohol exposure, offspring can have learning disorders, ADHD, executive function problems, anxiety, and mood disorders, as well as substance use disorders. Okay. Cocaine. Cocaine is another one that I'm sure you're not surprised we don't recommend. The primary concerns around cocaine use in pregnancy are due to vasoconstriction. So this can lead to spontaneous abortions, placental abruption, placental insufficiency. There's an increased risk of low birth weight, small for gestational age, and preterm delivery. Intoxication with cocaine can mimic preeclampsia, also because it can raise blood pressure. So then that can predispose the patient to be at risk for an unnecessarily early delivery. It does not appear to be a teratogen. But there is data to suggest that there's long-lasting effects on child growth and neurodevelopment. And again, increased risks of things like ADHD, ODD, poor executive functioning, and poor language development. These studies are very difficult to interpret because there's a lot of confounding variables. Usually, if a patient is using substances, they're usually using more than one, even if they're not doing it on purpose, because oftentimes supply on the street is contaminated. And there can be other socioeconomic factors involved as well. Okay, stimulants. And so there's the therapeutic stimulants with things like, Ritalin, Adderall, ADHD medications. And then there's the stimulants that people are using as substances of abuse. And they can be the same medications just being used inappropriately, or they can be like methamphetamine. For a long time, there was a lot of concern that even with therapeutic use, there were the same risks. What we know now that the big risks, such as, again, placental insufficiency, vasoconstriction, poor blood flow, abruption, those are the things that we see with abuse and with binge use pattern. It appears that if you're looking at normally prescribed doses of ADHD medication under physician supervision, we're not seeing that effect. And those pregnancies progress safely and well. There does not appear to be teratogenicity from these medications. There may be mild impact on fetal growth, but again, at normally prescribed doses, that seems to be very minimal. We do recommend for patients who do have ADHD and are being treated, if they're taking their medication in pregnancy, they take the sort of the minimum tolerable dose. And sometimes maybe even on an as needed basis. But we don't tell patients who are taking ADHD medications that they have to stop in pregnancy. Okay, opiates. So I'm going to spend more time on this one actually. Partially because it is so lethal and partially because this is the place where we have the best data for intervention and treatment. So the best evidence for opiate use disorder in pregnancy is to treat it with medication. You will often hear terms like MAT, medically assisted treatment. The substance use disorder community is really trying to move away from that language because it feels very stigmatizing. Nobody refers to insulin as medication assisted treatment of diabetes, right? We just say these are your medicine. So we're trying to kind of keep that in mind and speak more like that with patients, that this is just the medication for your illness rather than calling it MAT or anything else. Like anything else in pregnancy, there's no official FDA-approved treatment in pregnancy. However, we do have a lot of safety data on methadone and buprenorphine to know that it is safe and reliable. There's less data for naltrexone, but what is available is reassuring. We do know that opiate use disorder perinatally has a very, very high risk of relapse, especially in the postpartum period. So we want to be extremely careful with these patients. The gold standard is that they do proceed with medical treatment. Some patients feel very strongly that they want to be detoxed, and that's their choice. That is not technically the gold standard recommendation. And so when patients are asking for that, we discuss the fact that that wouldn't be the first recommended choice because they would have to be weaned off or detoxed. They could have withdrawal symptoms, which can increase the risk of spontaneous abortion. We also know that patients who choose to go through pregnancy without medical management are at higher risk of relapse. And if they relapse, they're at higher risk of overdose because their tolerance may have gone down from their previous use. And so they may inadvertently overdose because of that. But again, patient choice. And if that's what they want, we help them get through that. There have been some studies looking at patients who go through pregnancy without medical treatment. And there are some harms that I've already mentioned. Like there is a higher rate of miscarriages in that patient population and a higher rate of relapse. But patients sometimes are so worried about neonatal withdrawal in the postpartum period that they would rather take that risk. For women with opiate use disorders, there are very significant benefits both to themselves and to their fetus for taking medication. On the patient side, there's a 70% reduction in overdose-related deaths, which is very significant. They're less likely to have to contract HIV, hepatitis B, or hepatitis C if they're getting medication. They're more likely to be well-connected and engaged in prenatal care. For the fetus, being on medication helps reduce sort of the fluctuations that you would regularly see in more of a use pattern where there's going to be periods of intoxication and withdrawal, which causes stress to the fetus. There's less chance of intrauterine fetal demise with medication management, less intrauterine growth restriction, and less preterm delivery. If you're using methadone for treatment, one thing that's very important to keep in mind is with the metabolic changes of pregnancy. Often what patients will discover is that their previous therapeutic methadone dose is no longer sufficient to control withdrawal and cravings. Usually towards the end of the second trimester, middle of the third trimester, what patients will notice is towards the end of the day, they're having cravings or frank withdrawal symptoms, and that is because they're metabolizing their methadone faster. The solution to that is actually to split dose. That sometimes has to be coordinated with the methadone clinic because many clinics are only open in the morning, And so there has to be an arrangement made for take-home dose for the afternoon. Increasing the dose is usually not sufficient to solve this problem. It's a split dosing that they need. And then on the flip side of that, as soon as they deliver, their now elevated dose is going to be too much. And so it needs to be reduced. And we've actually had some pretty sad situations in the hospital where we weren't on top of that. And so then the patient's very sedated postpartum, and people are either worried that something medical is happening to them, or God forbid, you have a situation where they're sedated and they accidentally drop the baby. But you want to make sure that if they increase their methadone at the end of pregnancy, it needs to be reduced after delivery, or they're going to be too sedated. Buprenorphine is now becoming kind of more gold standard treatment. And it really depends on the patient what's better for them. Methadone is still a program-based treatment. You have to go there every day to get your dose. And for some patients, that actually works better because they have a place to go, someone to check in with, somebody who's like kind of keeping tabs on them. For many patients, it's really cumbersome to have to do that. It can interfere with their ability to hold down a job if they have to go to a clinic every day. For some patients, also the stigma of showing up in a methadone clinic with like a very gravid belly may feel uncomfortable. So for those patients, buprenorphine might be a better solution because buprenorphine is an office-based treatment. Now that the FDA has removed, the DEA has removed the requirement for an X waiver, everyone who has prescribing privileges is allowed to prescribe buprenorphine. And I would really strongly advocate that you get comfortable and learn about this and really take it on. It's not hard to manage buprenorphine outpatient, and it can be really life-saving for our patients. There in the studies that compared buprenorphine to methadone head-to-head, we don't really see any significant differences in outcome in terms of like relapse rates or effects on the fetus. If anything, buprenorphine looks better because buprenorphine is less likely to produce a withdrawal syndrome in the newborn than methadone. And buprenorphine is more protective in case of overdose or use on top of the prescribed medication compared to methadone. So in some ways, it's actually even more protective. This is buprenorphine also has fewer drug-drug interactions. Again, the office-based treatment can be much more convenient, less severe withdrawal for the newborn, less overdose risk. Subutex is the brand name for buprenorphine solo product. And technically, the literature would suggest that that's the one that's preferred in pregnancy because it's only one compound rather than Suboxone, which is combination of buprenorphine and naloxone. In my experience, I tend to not switch patients if they're already on Suboxone because Subutex is harder to find at the local pharmacy. And so I have found that when I have tried to make it like perfect and switch them, they've had gaps in access to medication. Sometimes the Subutex also has a different taste, so patients may not prefer it or insurance may not cover it as well. So I usually, if they're already on Suboxone and doing well, I don't change it, but Subutex is the one that does not have naloxone in it. This is a study that just was published 2 days ago, so hot off the presses, comparing patients in Tennessee with opiate use disorders in buprenorphine treatment or not. And one of the things, the red boxes are the things I wanted to highlight for you. So severe maternal morbidity improved very significantly with buprenorphine use. Preterm birth, less likely with buprenorphine use compared to no treatment. Admission to neonatal intensive care unit, much less likely to happen for patients who are taking buprenorphine compared to those who are not. Neonatal opiate withdrawal syndrome, less likely in patients taking buprenorphine than not. Small for gestational age baby, less likely. And any primary adverse outcomes of pregnancy, also less likely seen with buprenorphine treatment. So again, another data point about how safe and effective this treatment can be. With buprenorphine, much like methadone, we do worry about metabolic changes related to pregnancy. And so patients may experience that their previously effective dose is no longer sufficient and may need to either change their dosing from a twice a day to a 3 times a day schedule, or just increase the dose. The other thing with buprenorphine that you have to consider is that, unlike with methadone, when you start buprenorphine, if the patient is still actively taking another opiate, a full agonist opiate, because buprenorphine is a partial agonist antagonist at the receptor. If the patient is taking a full agonist opiate and you start the buprenorphine has a higher affinity, meaning it binds better to those receptors and will kick the substance that they're already taking off those receptors, and that can lead to precipitated withdrawal. So technically, when you start buprenorphine for a patient, they actually have to already have withdrawal symptoms, or they should have not taken their opiate in some time and they're just worried about a relapse, and that's why they want to get on medication. There are now protocols, and we're actually working on this in MCPAP for moms to try to update our toolkit to include this. There are now protocols to do what's called a microinduction. So you start with a much lower starting dose than in the standard protocol, so that the patient can continue to sort of live their life as they were, and if they're still using the substance, to continue to use it at that time until they build up a therapeutic level of that buprenorphine that they can stop the other substance and not have those withdrawal symptoms. One of the things that we're finding in working on updating our toolkit to include this is that in the era of fentanyl, which in Massachusetts, by the way, any patient who's telling you that they're using heroin, we don't have heroin in Massachusetts, we only have fentanyl at this point. It makes it more difficult to manage this because of how long the half-life of fentanyl is and for how long they can have that like withdrawal situation happening. So one of the things that we find is that sometimes you actually have to admit patients into the hospital to do this under medical supervision to prevent them from having like a very severe and uncomfortable withdrawal syndrome. Because again, if they go into full withdrawal, they do run the risk of having a spontaneous abortion with that. The other thing to think about with buprenorphine that's different from methadone is that because it has that partial agonism antagonism, you have to think about pain management. Both buprenorphine and methadone at steady state dosing are not going to be sufficient analgesia to manage the post-delivery pain needs. Now, for most women nowadays postpartum are not getting opiates, right? They're mostly getting like their NSAIDs or their Tylenol. And so these patients can do that too. But you do have to keep in mind that patients with opiate use disorders will often have a tolerance for the medication and often require higher than is expected or higher than typical pain medication doses to achieve the same pain effect. When I was the trainee, one of the things that we had to work with our anesthesia colleagues is they were advising patients to taper off their medication so that pain management would be easier postpartum. That's the wrong advice. Remember that this is a very high risk time for relapse, so the last thing you want to do is take their medication away. The correct thing to do is to continue their home medication at their prescribed level and treat the pain on top of it. And so if they need more pain meds on top of it, that's okay. Do that as you would with any other patient and leave the baseline opiate use disorder medication plan in place. In terms of the newborn, one of the things that's very confusing both for clinicians and patients is all the acronyms sound the same. So when we talk about NAS or neonatal adaptation syndrome, usually we're talking about that in the context of like adjustment to child being outside the womb and being unhappy about that, like the child itself being kind of fussy and cranky because it's cold, it's bright, it's loud, and they don't like it. And we see that can also happen with SSRI use, but that's not a withdrawal syndrome. When we're talking about neonatal withdrawal, the new acronym for that is neonatal, sorry, I'm blanking on it, but it's like NAS. So it's very confusing, the NAS versus the NAS. The point that patients need to know about ahead of time is that their newborn may have withdrawal symptoms from the opiates. And the number one best treatment for that is breastfeeding and cuddling. So skin to skin time and breastfeeding. And if the patient is taking their medicine for their opioid use disorder, and a little bit of that is getting through in the breast milk, that's fine too. That's going to help the baby get through their withdrawal process as well. Sometimes babies do actually need to be detoxed in the hospital, and there are rating scales that the nurseries will use to see if a baby actually needs medication to help it in the first couple of days getting through that process. And patients do have to be prepared that if that happens, the baby may need to spend an extra few days in the hospital as well. Sorry. So naltrexone, as I mentioned before, there's less data on naltrexone use in pregnancy than we have for buprenorphine or methadone. The human data is limited, but the animal data suggests that there's no teratogenetic effect. From the limited human data that we have, we don't see any obvious teratogenetic effect either. If a patient is stable on naltrexone, it's very reasonable to continue it. The data for Sublocade, which is the once a month injectable naltrexone, is even more limited than the oral. But again, I think when we're comparing the risks of relapse and the risk of the substance use disorder, it's going to outweigh whatever risks of naltrexone we're worried about. And my colleague is texting me, it's NOWS, neonatal opioid withdrawal syndrome. Thank you, Gina. Okay, so what can we do at MCPAP for Moms to help you with all of this? Hopefully you're all familiar with MCPAP for Moms. We're a Massachusetts-based program, peer-to-peer consultation. Happy to help anytime. We are very proud and worked for a very long time to create a toolkit for substance use disorder treatment in perinatal patients. This toolkit exists both on our website for free, but if you are interested in a hard copy because you're a geriatric millennial like myself who likes everything on paper, just contact us and we're happy to mail it to you as well. The toolkit is based a lot on like what this talk was based on. So we kind of cover the different substances that we encounter in pregnancy, the effects that they can have on the patient, what the withdrawal symptoms may look like, how to manage the withdrawal symptoms. We also have screening tools, as you saw in my talk. And then we also have resources on how to direct treatment and where to find community treatment partners. There's some algorithms for treatment interventions as well. These are additional resources. We are currently trying to update our toolkit to include some of the microdosing information that I was alluding to, and also more trauma-informed care principles to help guide alliance building and making sure the patients are comfortable with us. And the other part of MCPAP for Moms is don't forget that you can call us and talk to one of us if you have questions about how to best manage a patient. We also are happy to set up trainings at your sites if you guys have teams that would like to learn more. And then, of course, on our website, all of these materials are there for free. This webinar will be posted there for free, and there are many other really useful webinars on the website that may be of interest to you as well. Okay, I'm done. Happy to take questions.
Thank you, Polina. Wonderful talk. And I know we have a lot of you out there, so you can type a question into the chat or unmute yourself, and we'd be glad to have, Polina would be glad to answer your question. We'd also take questions if you're finding barriers to good treatment of your patients out there, that we're always looking at ways to help improve the system. So this is a good opportunity if you see something that's making it hard for you to take care of this population of patients. We'd be also glad to hear that.
I have taken Jennifer Hinton off of. She can ask her question. She had her hand raised.
There we go. Now I can unmute. I couldn't put anything in the chat for some reason, so sorry about that. I was wondering, I came a few minutes late, my apologies. Wondering if we would be getting any of the slides after this presentation?
So the slides will be on the MCPAP for Moms website under webinar. There's
Great.
always the recording of the webinar and then the PowerPoint next to it.
Wonderful. Thank you so very much.
Sure. I do see that there's some questions in the chat. There's a question, is it recommended to transition mid-pregnancy from methadone to Suboxone? It's an interesting question. Very good question. I wouldn't say that it's recommended per se. And when it comes to treatment in pregnancy, I often like the adage of if it ain't broke, don't fix it. And partly, you know, there's pluses and minuses to changing something mid-pregnancy. The big minuses are this pregnancy has already been exposed to methadone. This fetus has already been exposed to methadone. So we're always trying to minimize the number of exposures in the pregnancy. So if you're now introducing buprenorphine, that's another exposure. And what if it doesn't work, right? There's also the risk that you're destabilizing the patient, because I have met many patients who say, I don't like the way buprenorphine works or the way it makes me feel. I prefer my methadone. So I think it depends on patient preference and why they would want to make the switch. The other thing to keep in mind, transitioning from methadone to buprenorphine with a traditional induction plan is very, very hard, because methadone has such a long half-life that risk of precipitated withdrawal is very high. So in the classic induction to buprenorphine, the patient has to be in active withdrawal before you start the buprenorphine. And with methadone, that can be a very long time period and can be very uncomfortable. Microdosing would be the situation where that would work better. But that is less commonly used right now. And so it would depend if you're comfortable with a plan like that. Sorry.
Paulina, we have a question about people who are using energy drinks that have a lot of caffeine in them.
Interesting. I have to admit, I've never looked into that. I am a big coffee drinker. So I do think that caffeine in pregnancy has a bad rap. Some of the studies saying like caffeine is detrimental in pregnancy were like very high doses, like very high, like something like eight coffees a day or something like that. So I think it would depend on how much caffeine they're taking in, and if they could cut back, but it doesn't have to be zero. Tobacco in pregnant. Okay, can you speak on the effects of using tobacco in pregnant moms who are also taking harm reduction meds to other substances? Okay, tobacco is a complicated one too. So we know that tobacco is bad in pregnancy. It is teratogenic and it can cause growth restriction. I don't know how much data there is on smoked tobacco versus nicotine replacement for that. I'll admit I have not looked into that, whether using a nicotine replacement product would mitigate that risk. Smoked tobacco cigarettes have other, just like with cannabis that's coming off the street, you know, we're worried about the other additives and the other things that are in it. So it's not like a pharmaceutical grade pure substance. The gold standard for trying to help patients stop tobacco use in pregnancy is bupropion or Wellbutrin.
What about a question here about breastfeeding and substance use?
Yeah, so again, it sort of depends on which substance you're referring to. If a person is taking their buprenorphine or methadone, we do not advise them to stop breastfeeding. If anything, the outcomes are better for the neonates if they continue to breastfeed. Alcohol and breastfeeding is complicated. Alcohol definitely crosses over in milk. Some people recommend pumping and dumping. I don't ever advise patients to do that because it's just too hard. And it's not an exact science when exactly you would dump and feel like your supply now does not have alcohol in it. I would advise patients, again, I think moderation is important here. If you had one glass of wine with dinner, and then you go to breastfeed, I don't think that's going to cause any harm. If you're binge drinking, you know, the psychiatrist in me feels like that's problematic whether you're breastfeeding or not, and why are you binge drinking? But definitely alcohol, you have to be careful with breastfeeding. The other thing that's important for patients to know that it's a myth that alcohol improves milk production. It does not. It actually reduces milk supply. But there are studies out there that babies actually drink more milk when there's alcohol in it. So that is a little concerning too. Cannabis, I really don't like patients to breastfeed with cannabis just because it's so concentrated. With the stimulants, we will talk to patients about monitoring the newborn, because stimulants can cause appetite suppression and sleep disruption. And a challenge with a newborn is you don't really have an established pattern of either of those things, so you're not really aware that there's a change. So if patients want to breastfeed and need a stimulant, we will often talk about, do you need it right away? Or do you maybe not need it while you're on your maternity leave, but will need it when you go back to work, when the baby has a more predictable sleep cycle and is bigger, frankly, and can digest things better. But if you are going to be using a stimulant in lactation, I do advise coordinating with the primary care doctor, because they may want to keep closer tabs on like weight gain and making sure that the baby's staying on its growth curve in the way that they want it to.
Sarah Dublin, you have a question there that maybe you could come off mute and ask, because it's a little confusing about, is this, because Polina did cover about if someone's on MOUD and is stable, that there isn't a need for reporting at this point. So could you make a little clearer what your question is? She may have left.
Okay. Well, maybe I can kind of generally answer that. So,
Hi there.
oh, sorry, you're here. Great.
I was able to come off mute. To clarify, when I work in the social work department at my hospital, and if we meet with a person who is pregnant or delivering, and they've been using like illicit substances like cocaine or fentanyl during their pregnancy, and perhaps they aren't on a maintenance medication yet, that's when it becomes like our responsibility to file a DCF once the baby is delivered. And so I'm just wondering, but yeah, I agree. If it's not our hospital policy to file if the person is being maintained on buprenorphine or Suboxone. I'm wondering about the situations where the person is still actively using substances and they're not on a maintenance medication. If you guys have any recommended best practices for starting that conversation with a patient in a way that's like empowering to them and helps them with their understandable fears.
Yeah, absolutely. And I think this is the part that's so important to highlight to patients, because this is a change that's only been around for like what, maybe 3 years at most. It used to be that even buprenorphine, even, Percocet for a broken leg was being reported. So I would say I can speak for Brigham, where I'm familiar with our policy, and I'm pretty sure BMC is the same way now. If a patient is in active treatment at the time of their delivery, I don't think the teams are automatically filing. There may be gray areas where, like, if the patient started active treatment the day that they were admitted to the hospital, maybe they're not going to feel so comfortable with that. But somebody who in pregnancy began engaging in treatment, is doing their follow-up, is presenting to care, is sort of like working with the team, our teams are not filing for that. The patient who isn't doing that, they are still filing. And one of the things that I've seen also happen quite a bit is patients show up just to deliver. Like they haven't had any prenatal care, they haven't engaged with anyone in treatment. And those are definitely still being filed as well. So I think it's another way to maybe engage the patient, is that, hey, if we can get you hooked up with the team, if we can get you in treatment, maybe the whole DCF situation can get avoided.
I think that, Polina, would you say it's fair to say that to the extent the patient can engage, even if they haven't been, then the risk of the baby being removed, maybe the mom may need family may need supervision, but that's different than
Yeah.
having your baby removed. So
Yeah.
again, it's a complicated situation, but that does need to be something that DCF sorts out.
And this is where it's so important to do, you know, the plan of safe care, or the we're now calling the family plan, is to get it on paper and get it formalized to be like, this is your team, these are your doctors, these are your counselors, this is your support network. Because even if the providers do feel that a filing needs to happen, it's still better to file with all of that in hand, to present it to DCF of like, we're on it, we're on top of it, we're all working together. Then this person just showed up, we've never met her before.
Okay, I thank everybody. I think we've reached the 1 o'clock hour. Thank you, Dr. Tessler, and we thank everybody who attended, and you can always email us questions or call us. Remember, you're going to get a little survey after you hang up, and the recording is and the slides are available on our website. So thanks and have a great day.
Thank you, everyone.